Good evening, and welcome to the Caring View, the online health and social care platform, free to access to absolutely everybody. Let me just move my little George out of the way before we get started. He says hello, and he doesn't know personal space. Before we get started, don't forget to hit that like button, hit that follow, that subscribe, follow us on YouTube, Twitter, X, LinkedIn, Facebook, Instagram. We are live on Instagram tonight as well. www.thecaringview.co.uk for all of our latest podcasts, chat show episodes, and free resources, including our CQC guides. Very important with tonight's conversation. And did we mention it's completely free? It doesn't cost you anything at all to access any of our resources. We do that through the generous donations of our sponsors. So a huge shout out to our sponsors. Prosperwell, they are the leading digital marketing company in the country. It says one of, but they are definitely the leading one. Tea with Toby, go check those out. We have CBAT, Care Business Associates Training. If you know Paul Blaine, he's on a massive health trip journey at the moment, so please go and follow him on that, but also go and check out the training from CBAT. They do CHAPS training, which I am looking at this moment in time as well for some of our team, so please do go check out CBAT. And Attis Care by Attis Insurance, brokers for all of your comprehensive care coverage and proactive risk management. Without these guys, we would not be able to do what we do. I think that's all of our intros. We have got a podcast that has gone live this week, Mark, I believe, around the Me Passports.
We do indeed, yes. So I sat down with the founder and director, Kylie Rochester, a few weeks ago now, just to look at what they are doing within the social care space, and actually really exciting things. So a digital passport full of your skills, your experience, your work history, references to speed up that recruitment process. So yeah, really exciting. So make sure you check that out, because it will be coming across the United Kingdom anytime soon.
Exciting stuff, and it's a really good listen. It's a nice short podcast. It's a good one to fill a car journey in between sites if you're traveling around or on your way to work. So do go and check that out. I'm going to apologize if I'm in and out of focus or in and out of brightness. The sun coming through this window at the moment is incredible. I know we moan about the rain all the time, but I could be doing without this right now. Tonight's episode, we are going back to basics. We are intimate tonight. It is just you and I, Mark. You and I.
In a way, it was quite nice. I get the anxiety every Tuesday evening that a guest might not appear. So it was quite nice knowing that it was just us two. But it feels strange, just the screen with just us two. But no, it's all good.
And you almost didn't have me. I've had blooming flu the last couple of days, which has been absolutely horrendous. Flu in summer, who'd have thought it? But it's been absolutely gross, minging, just gross. But I am back, fighting fit, ready for tonight. So Mark, tonight, CQC. The framework is here, it's in place. They have started the inspections under the new framework. Whether it all works or not, please do let us know in the comments. If you have had a CQC inspection under the new framework, please do let us know. I'm going to have to close this curtain. Please do let us know if you've had, oh my God, now you can't see me at all, an inspection under the new framework. We would love to hear from you. If you're struggling with the portal, let us know. We want to know about that as well. But what Mark and I want to do is really break down the framework itself now, go through these quality statements and what should we be doing, how should we be preparing, and what do we need to know to excite the CQC and get our ratings to those goods and outstandings. That being said, we're not doing it all in one episode. We're going to split this over 5. And tonight we are literally just going to focus on the safe domain of the CQC framework and those quality statements as well. I do just want to start off tonight by saying the PIRs are still very much alive. Now, we did have conversations with the CQC prior to the framework coming in, and they have expressed their desire to retire the PIR, which obviously huge jubilation. Everyone was like, yes, it does not take 7 hours, it takes 7 days. It's ridiculous how long it takes us. And it is an annual thing. It isn't one of those where it's that sort of harbinger of a CQC inspection anymore. It is just an annual return that we have to complete, but they are very much alive. I say that because ours has arrived to one of our homes recently. What I want to talk about, though, is the use of the PIR and how we can make that benefit us. So we all see the PIR as this thing that we've got to send to the CQC. It's this really annoying document. How do we document everything that we've done? How do we fill it in? And we sometimes forget at the end of the year what we have done. Or worse, we get to the end of the period and we get our PIR on our doorstep and we start filling it in and go, actually, we could have done that, and we could have done this, and we could have done this, and we could have done that. And that would have been really good to evidence if we'd have done this. So what I've started doing with my team, and this is something please feel free to go and do with your teams, start your PIR a year early. So when you know your PIR is due, it's usually your date of your registration, plan 10 months before to really start going through that PIR in preparation, because then you can plan out your next 12 months. So get to the EDI section. What could we have done for EDI that would have benefited the life of our residents? Well, we could have done this, 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 and this. Well, it's no longer we could have done. That's what we're going to do. So you plan that out over your 12-month period. So by the time your PIR comes through and you're asked to document the evidence, you've actually already done it because you've planned it in advance. You've got your action plan. You know what you're going to do. You've got the evidence to fill it in. PIR becomes a doddle at the end of that 12-month period, and you've got all that wonderful evidence to send off to the CQC, and hopefully they'll go, oh, wonderful. Maybe we should consider a rating change here. Maybe we should consider celebrating this organisation. And who knows, by the time that comes around for you and your PIR submissions, the portal may be working and we may be able to submit our evidence through that. But that was just some thinking that I've had around the PIR. I use the Radar governance system. I'm not affiliated with them, we just use them. And I've actually built the PIR into our governance system so that the team can fill it in throughout the year. I can check it wherever I'm at, and we can use that at meetings now and have those discussions around what could we do about this section, what could we do about that section. And then for all your number data inputs, you can just keep that up to date as you go along throughout the year. Now, Mark, if only there was a podcast to help people through completing the PIR, wouldn't that be really helpful?
That would be very helpful indeed. Good job we've got one.
Oh, we do. It's a 6-part podcast available directly on our website. You can go to one of the drop downs and we've already put it into a playlist for you on there. If you go into the website, you can listen directly through the website. You can go and listen on Spotify, free accounts on Spotify, or all of your other podcasting sites, as well as YouTube Music, I now believe. I think we have successfully gone on to there. But Mark, let's get on to SAFE and the quality statements under SAFE. Over to you.
Yes, so I thought we'd start by just explaining what the CQC SAFE is. So on their website, and I'll share the link in a minute into the comments, it says safety is a priority for everybody and leaders embed a culture of openness and collaboration. People are always safe and protected from bullying, harassment, avoidable harm, neglect, abuse, and discrimination. Their liberty is protected where this is in their best interest and in line with legislation. And then it goes on to talk about where people raise concerns about safety and ideas to improve, the primary response is to learn and improve continuously. There is a strong awareness of the areas with the greatest safety risks. Solutions to risks are developed collaboratively. Services are planned and organised with people and communities in a way that improves their safety across their care journeys. People are supported to make choices that balance risks of harm with positive choices about their lives. Leaders ensure there are enough skilled people to deliver safe care that promotes choice, control, and individual well-being. So I think for me, it really lays it out quite simply what the CQC expect. And I think one thing when I talk to managers that are struggling with the new framework is that I think historically there was the outstanding guide, wasn't there, that the CQC had, and everybody kind of tried to embed that to then get that outstanding. Whereas now we don't have that guide. But I do think if you put some time aside, and probably for each key question, you probably want to put maybe half a day aside, really sit down and understand each one of them. Actually, all the information that the CQC are expecting is all laid there. You just don't have it in a printable guide. It's just on their website. Adam, what are your initial thoughts around that kind of it?
No, I mean, I totally agree. I mean, we all think of SAFE as the generic keeping people safe, which it totally is. But I think when we talk around the safe domain, when it comes to regulation, we always think to ourselves, we can't make mistakes. And we become this sort of paranoid sector where it's like, we cannot make a mistake, when actually it has to be something completely different, where it's we are going to make mistakes. What matters is how we learn from that and how we improve and how we embed real change and how we prevent those mistakes from happening again. So I would be saying to people, you know, don't be afraid if you've had mistakes in your service. You've had medication errors, you've had falls, you've had abscondments, you know, people leaving your service without being aware of it. Sometimes they just show us where we've got chinks in the armor and where we can focus on repairing that armor. I mean, obviously, in an ideal world, we don't want to make mistakes. We don't want to bring harm to people. We don't want there to be harm within our service. But it is completely impossible to mitigate all risks and to mitigate all harm. What the CQC are looking for here is actually, what is that learning culture? What is that improvement culture? How are you how are you even checking your services to make sure they're safe? How are you putting in that preventative work to start off with? Now, I think we'll link to the regulations throughout this as we go through. But it is, you know, it goes without saying that one of the big regulations that we're looking at throughout the whole safe domain is Regulation 12, which is safe care and treatment. So if you don't know your regulations, why not? Please do go and check them out. And a top tip for you all is when you're doing your work and you're going through these quality statements as your companies, as your organization, and you're putting together your learning plans for the year, when you're doing your work with your team, remind them of the regulations as well. You know, let them know what the regulations are about and what they do. So Regulation 12 being one of the biggies, make sure we look at that. Regulation 17 as well is one that is referenced quite a lot throughout the safe domain, and that's around good governance. And that also links into your leadership side of things, your well-led side as well. But yeah, I think the safe domain's the nicest one to really go through, isn't it? Caring as well. I think caring's your good one. That's a really easy one to tick your boxes off. Safe is the next one, where we should have that primary focus, but actually is also, when you sit down and think about it, quite easy to appease.
No, definitely. So I have shared the link in the comments. If there's anybody who wants to have that in a separate tab open as we're talking, you can kind of click through the website alongside us. So it then breaks it down into 8 sections underneath safe. So the first one is learning culture. So you have the quality statement. We have a proactive and positive culture of safety based on openness and honesty, in which concerns about safety are listened to, safety events are investigated and reported thoroughly, and lessons are learned to continually identify and embed good practices. And then underneath that, you have 6 points of what that quality statement means. So really breaking it down into actually, that is what you need to be able to evidence to the CQC. Adam, do you have any tips here around learning culture? Obviously, you've spoken briefly around some of the bits, but
yeah. So I mean, let's go back to the quality statement for a quick second. We see that it starts with that we word. All of the quality statements are we statements based on work that was done with TLAP, and we also have the I statements as well. The I statements are what reflects what people say around their care, and that's the sort of questioning and the sort of responses CQC will want to hear from the people who use our services. When it comes to this quality statement, for me, again, it is that whole continual improvement, isn't it? It's how we're evidencing that journey that we've been on. I think we all should have duty of candor embedded within our service. And that's something we should have embedded at all points. And we should always be asking ourselves, whenever an event happens, does this trigger the duty of candor? And what notifications do I need to be sending here? What do I need to be recording here internally? And the other question that I would ask ourselves as well is, when it comes to safe, and this, so everyone's touch wood. If you've got wood around you, touch some wood. I've not, so I'm going to touch my head. I don't know whether this desk counts as wood. Is always look, for me, worst case scenario as well. If you're one of your senior managers and one of your senior leaders, and a mistake has happened or something has happened that's put your service into an unsafe position, always ask yourself, if this incident ended up at inquest, have we got enough information, and have we recorded enough information, and have we documented enough to support the actions that we've taken, to support our thought process and to support our decision making? Because it's one thing, it's one thing to say, actually, we've identified this and we've done this and we've done that and we've done this. If you've not written it down, if you've not documented, if you've got no evidence of that, how are you evidencing your working practices? How are you evidencing that work you've done to improve your service? it's also around making sure that you've got that open culture. So for me, it's around making sure that if someone's coming to you saying, I've got a safety concern, that you're acting on that, you're evidencing it, you're recording it and documenting it, and then you're feeding back around what you've done to improve that safety. I would say, this comes alongside working with other partners and other partnerships. But I would also say around having that open culture with your local quality team. So do you meet regularly with a quality team? Do you meet regularly with the commissioners or with the ICB? And what's your relationship like with them as well? Because the evidence categories are in place now. So it's no longer just an inspection to give you your rating. Feedback from people who use your services, feedback from staff and leaders, and feedback from other professionals, basically. So actually, what's your relationship like with them when you're discussing the safety aspects of your home? Are you just sending them a courteous email to go, FYI, this has happened this week. It's not really affected us too much, but just so you're aware, in case anything comes through safeguarding or anything comes through from the CQC, we're just keeping in touch and letting you know where we're at. Because that openness and that honesty, or even saying, is there anything else you would recommend that we put in place? This is everything we've done to sort of mitigate the risk moving forwards. But we invite your sort of feedback and we invite your conversation on this as well. Obviously, we don't want to be going and creating a rod for our own back or whatever the saying is. We don't want to invite trouble where trouble's not required. But there is that element of actually, is there anyone out there within the system that can come and help us as well? Is there anyone out there that can give us that outsider perspective to go, actually, this happened in the trust once, and this is what we did about it. Could you consider that as well? So I would say it's around having those open conversations and with your team. So learning lessons, learning outcome, lessons learned, silver linings, whatever we call them in our organizations, it's fine and great for us to sit there, do an investigation, do a root cause analysis, go deep diving into what the issues have been. And we've gone, well, this is a lesson learned, and this is that, and this is this, and this is that. Great. How are we communicating that back out? So how are we communicating those lessons to the team, to the people that actually really need to know what the lessons are that we are learning? Because chances are we know these inherently, but actually the rest of our team need to understand that impact, need to understand what we've learned from this, and how are we sharing that across our organization. If you are one home or one home care service or one individual service, whatever your setting may be, it's a lot easier. You can do it in your team meetings. But if you're a group, are you learning as a group? So do your group managers get together and share the lessons learned from each of the services, so actually all your other services can learn from it as well? You know, for example, we get together in our organization every single Monday, all of our registered managers, and one of the questions we ask is, right, what lessons have we learned this week? In the last 7 days, what's happened that we can learn from each other on? Because that's that peer review, that's your peer support. But then that also goes down as peer supervisions as well. So if you're doing those meetings where everyone gets together and you're sharing your lessons learned, you're sharing your outcomes, you're sharing knowledge, you're sharing information, you put that down as a peer supervision. So actually your managers get that supervision on a weekly basis. And you're ticking so many boxes later on down the line when we're looking at those other quality statements, especially when we get to that sort of well-led angle. But as we mentioned, as part of this whole safe domain, it's around having the appropriate number of skilled team members to be able to provide that safe support, and that only comes from nurturing and growing them as well, which always comes from how are we learning, what have we learned, how do we implement this?
No, thank you very much. And I think just touching on kind of those lessons learned, sorry, it's also around the learning from any audits or in kind of internal inspections that your service is doing, whether that's you're a one-off care home care provider, or whether you're a group. And again, how is that shared across your staff team? And I think listening you talk there, Adam, around supervision, I'll pull out the link in a minute and pop it in the chat. A few weeks ago, we had a really interesting and meaty conversation on supervision in social care and what that kind of looks like in the future. And actually, supervision doesn't have to be something that is touching on health and safety, touching on whatever. It can be something that is informal. It can be, like Adam said, that group supervision of cross-learning. And actually, the CQC very rarely check the content. They want to just know that it's happening on a regular basis. When I was looking through some kind of CQC reports over the weekend in prep for this, just some common pitfalls that come out. So one around recruitment, gaps in employment in staff files was a big one. ended up getting them a requires improvement in safe and in well-led. So one thing I'd definitely recommend is go back through your staff files and do an audit on each and every single one. Depending on how many staff you've got, it could be a very big task, but actually it's going to save you in the long run. The gaps in employment records was around actually not having the months. The people had the year but didn't have the month. So you need to make sure that actually there are no gaps. And if there are gaps, that you've got risk assessments or documentation that explains what that is, were people on maternity, were they looking for work, poor staffing levels. So I think we see this in a lot of manager groups and hear it from a lot of managers around actually, does anybody have a dependency tool? Actually, you need to be making sure that you've got the right staff. A couple of the reports spoke about this staff mix in terms of skills and ability to meet the needs of the people being supported, especially in learning disability services, which I thought was really interesting. Infection control and cleaning records. So you might have the cleaning service, but if you haven't got the records around cleaning and hygiene and infection control, actually, again, the CQC will view that you're putting your staff and the people you support at risk of infection. And also, you spoke earlier around auditing and that lack of action taken from auditing. So definitely make sure that you've got a good action plan that tracks what the issue was, what you've done about it. And then I would go one step further and not just have a date completed, but what the impact was of that change that you've done, both to your team, to the leadership team, to the people you support, to the relatives, to people that you work with. Just so that you can get that clear picture of everything. Because what we need to remember is that CQC are still crossing that threshold. We know they're still coming, but there will be a time when they won't cross that threshold as much. And what we need to do is make sure that every bit of data that you're sending over to them tells a really clear picture of what you want it to tell. So make sure that you have all of your information fact-checked before you do anything with it. So actually somebody else in your organisation, and ideally somebody who's a bit more removed from it than you are, can actually say, yeah, this is telling me this story, or no, actually it's missing a gap here or there.
No, I totally agree. I totally agree. And all of those are really sort of great observations that we can all learn from. I mean, coming back to this quality statement, there are things that we should be doing now as companies where we can start putting things in place and actually just checking ourselves to make sure we're doing everything we possibly can do. So like we discussed at the beginning of this, take these quality statements one by one and start doing your work and start triangulating what you do to link into them. So under this quality statement, the learning culture one, incidents, complaints, CQC are saying, are they being appropriately managed? Are they being investigated? Are they being reported? Actually, what is your internal complaints procedure and your policy? Does your team know that? Go and ask them. Ask your managers, ask your nurses, ask your senior carers, your APs, your NAs, whoever you've got working, and go, do you know what our complaint policy procedure is? Ask your relatives, ask the people that use your services. Do they know what your complaints policy and procedure is? Do you know what your complaints policy and procedure is? Do you have it formalized? Is it really easy for people to follow? Is it foolproof? Do you have a set of forms that go from 1, 2, 3, and 4? Is it in your governance system? For me, around complaints and incidents, always document everything, even if it's a niggle. Knock, knock, knock. I'm really sorry to bother you, but Mum's wearing the wrong shoes again today. And I just, it's, I hate to nag you, but I want us to wear the right shoes. Not a worry. Let us look into this and we'll get back to you. Log it. Log that as a concern, because actually what you need to do from that is your learning outcomes. So instantly for me, if someone's wearing the wrong shoes, is this reflected in a multifactorial falls risk assessment? Because wearing the wrong shoes could give them a risk of falls. Last week, we had an episode all around diabetes foot management. Has this person got diabetes? If the answer to that is yes, have we assessed them for neuropathy? If the answer to that is yes, and they have got it, and they're wearing the wrong shoes, is that going to cause further issues for the feet? Is it going to put them at risk of ulceration and other diabetes-related incidents? So all of that is your lessons learned from what could have gone wrong. Fingers crossed, nothing has gone wrong. But then you then share that back to your team and go, look, we have this complaint, we did this investigation, we found that they are wearing the wrong shoes, and this is what we've prevented by picking this up now. Because people have been confident to come and tell us, we've prevented a fall, we've prevented a hospital admission, we've prevented a broken hip, we've prevented diabetes foot-related incidents, we've prevented resident-on-resident aggression, because someone else has seen them wearing the wrong shoes and actually they're their shoes. We've prevented future challenging behaviour issues or behaviours that present as challenging. So there's a lot of things that we can learn from those compliments and complaints. not just satiating the concerns that the relative has, but actually preventing future risk to the organisation. With that is raising concerns, and is the pathways in place for people to raise concerns? Do people know how to raise concerns within your organisation? So, have you got systems in place for that? Have you got have you got an intranet, for example? Have you got digital ways in which people can raise concerns? Have you got a concerns box? Have you got an open door policy? Have you got quality meetings or concern meetings that you have every week? Do you have flash meetings every day? You know, all of those different things are avenues where people can come and raise those concerns. Relatives, people who use your services, have they got that position, that ability to come and raise those concerns? Have you got a freedom to speak up champion? Have you got that policy in place where people are aware that actually they can come to you with these concerns without fear of repercussion? And have you embedded that? Have you got relative meetings going on? Have you got resident meetings going on? Are you documenting that? Are you evidencing that? Are you bringing up within that the ability for people to come and raise those concerns? One step further, do you have a resident association or a relative association? So do you have within your home setting residents that get together on their own without the need of nurses or HCAs or any of your team? And do they get together and have their own meetings and come to you with their concerns and their celebrations as well? Do you have a relatives association where the relatives get together? So it's really important that we have that through. Nicola's just come in into the chat and saying sometimes not receiving complaints is a red flag. Do people know how to? Do people know how to? Is there easy read guides? 100%, and that's what something. I always get a bit dubious if I go to a home and they go, actually, we've had no complaints for the last 3 months. I'm going, really? Surely someone's had a niggle. A team member, a resident, a relative, an external body. Someone must have had something to say. There's always something we can learn. We're never perfect. But Nicola's right. We're going to, the Accessible Information Standard, it's part of your PIR anyway, but we'll run through everything that we do is, have we got the different methods for people to understand our complaints policies and procedures? Have we got it in multilingual formats? Have we got it in easy read? Have we got it on big read? Can we print it out on paper that isn't white? So have we got yellow paper or blue paper that we can print it out on for people who have got things like dyslexia or other neurodivergences? You know, how are we making this information available to them? One of my favorite things that I used to do, and I'm getting back into the habit of doing it, is converting text to audio and making it available for people who can't read, but actually can access it audio as well, so they understand what that process is. So it is around making sure that people are aware of what that process is. You've documented that they're aware, you've given them that information, but it's more than just telling them that they can make a complaint. It's proven to them that they can follow through on that, and it's proven to them that you are learning from that. So feeding back your outcomes, feeding back what you've learned, feeding back what you're changing as well. Obviously, risks is a huge part of this. How are we managing risks? Are we risk assessing things? We're not ignoring them. We're acting on them proactively. One thing that I have around my home or homes is QR codes where people can scan and they just tell us on a daily basis how they found the home. That's team members, that's people who use our services, but it's also external providers as well. So a doctor comes, a district nurse comes, a commissioner comes, whoever comes, they can scan it and say, actually, I've had a really good time in your home today, or actually, I saw this and this was a bit of concern, or I wasn't satisfied with this. All of that feedback benefits as well. And obviously transparency. Are we being transparent about everything? Are we including everyone in this process? So we get a complaint through, it's about a specific person, we can't go into detail with the team, obviously, but actually, can we pull some themes from these complaints? Can we pull these themes and sit down with the team and go, look, these are some of the themes that have been discussed with us. This is what we're learning. What do you think? How can we change as a group? How can we change as a home? How can, you know, the daily approach to what we do change, and involve people on that process as well? Because one of the things that they will ask for is, how have you communicated this? Who have you communicated it to? Why have you communicated to them? Or why haven't you communicated to them? So it's around sharing all that information. You can have a you said, we did board. You can have said, this happened, we did this. Doesn't really matter the process in which you do it, as long as you can evidence that you're feeding all of that back. I think that's pretty much most of the things, apart from this is Reg 12 and Reg 17, this quality statement for learning culture. So your good governance and your safe care in treatment. I think you also need to be looking at duty of candour. I've already mentioned that already. And then you're receiving and acting on complaints. I will say, though, make sure your complaints policy is a complaints and compliments, because you also want to do equal for the celebrations. You want to evidence that you've had really good stuff as well. And that's just as important as having those complaints. So, do you know, I visited my mum today and she's had a really good day. Your home's fantastic and your team are really attentive. They've just done wonderful with it today. And I'm really, really happy. I'm really, really glad you said that. I really appreciate that. I'm going to write it down. If you've got the time, could you send it in an email as well, though? Because I'd love to be able to document that and share that with the team. Don't be afraid to ask people to back up their compliments. All of that is really great evidence for us to share with people. Mark?
Thank you very much. No, all good stuff. The only thing I was thinking of as you were talking there around risk assessments was around, we had a PAMS audit, and we've had a lot of people reach out to us about doing an event on PAMS inspections, their local authority inspections, and we're in talks about doing one this year. So we'll keep you posted. One thing that they picked up on in the service that I oversee was around risk assessments, and they were detailed. They had no problem with it. But actually what they wanted was a protocol for if that risk happened, so that staff had a really clear breakdown, step-by-step guide of actually what action would they take, which originally I kind of thought, well, that's the whole idea of the risk assessment, is to prevent that. So why would they need to go? But actually, when you then stop and think about it, actually, how many risks are we managing on a day-to-day basis? And how many of those are everyday things that actually we might know what to do, but how many of them are complex things? And we know that people's level of need is only getting more complex, that actually that step-by-step guide of what to do and the actions to take are actually really beneficial and have made a really big difference to our service. Just some lessons there. The only thing I would just direct people to on the CQC website as well, and I say this all the time, is around the best practice guidance. So best practice now, CQC expect providers to be aware of and to follow the best practice guidance. So as you scroll underneath the I statements, the subtopics, it's down there, it's a drop down arrow. So make sure that when you're spending that time looking through these quality statements, that actually you're taking time to look at what the best practice guidance is. A lot of it relates to NHS, some things that they haven't yet pulled through to social care. Focus on the social care ones first, but then once you've done them, is go in, see what the NHS are already doing and see what you can then embed into your own service. So, ready to move on, Adam?
Ready to move on.
So the next one is safe systems, pathways and transitions. So it says, we work with people and our partners to establish and maintain safe systems of care in which safety is managed, monitored and assured. We ensure continuity of care, including when people move between different services. So I think for me, the really interesting point here in the new framework is actually the point there, the last bit, including when people move between different services, because I think that is one thing in social care that we don't necessarily do great. I think it's got better since the pandemic, but I think there's always been that competition around, you know, actually is our care plan and we're not sharing it, especially if that person's leaving kind of under a cloud, which we all know that happens. But actually that person is in the middle, and actually if you can share the care plan and the risk assessments and with the person's consent, actually they don't have to go through that whole assessment. And I kind of think about my service that I manage, which is reablement. We're only with people for up to 6 weeks. We've developed a care plan. We know the goals that they wanted to work with after they've come out of hospital. We've supported them with those goals, and some people do obviously need ongoing care. Is actually for them to then have to talk about that whole journey around hospital discharge, goals, reablement, to then get to what they currently need. Actually, just sharing that care plan and the risk assessments, that providers should, we all know that we've got to do our own risk assessments and our own assessment of need, but actually it just cuts down some of that time that person's got to retell their story 2, 3, 4, 5 times.
Like a passport, isn't it? You know, it's that ability to be able to share that information. And, you know, I was just thinking, I literally just wrote down then when you said people say this is our care plan. Actually, the care plan belongs to the individual. It's their property, it's their notes, it's their information. And actually, we should be providing them that access. And I think part of this quality statement is all about that, isn't it? Is, are we involving people within their care journey themselves? Are they getting their loved ones involved, their circles of support, their LPAs, the RPRs? Anyone that's important to them, are they involved in that care planning process? Are we listening to what their concerns are? So when we do our care reviews, are we doing that sat in an office going, yep, all this care is the same, all care reviewed, no concerns or what have you? Or are we taking our laptops into the room with that resident and inviting their family down and going, do you have half an hour today to come down? We're going to do a full care review. We'd love you to be a part of that. Your loved one wants you to be a part of that, or you're an LPA, you need to be a part of this. It's really, really good practice. But also, we want to know where you are on your care journey so we can be informed, you are informed, and then we can share that with other people as well. The whole transition in between services, I know some people will think, well, actually moving between services might be leaving a home and that's it, gone, goodbye. But actually, when they're going into hospital, have we shared all that relevant information with them? How many times do we get phone calls saying, I need to know what this person's baseline is. Can you tell me what their baseline is? Have we got hospital documents that I can hear you all on the other side of the camera now going, but the hospital lose them. They never read it anyway. Totally get that. As long as we've evidence that we've done our bit and that we're sharing those pathways with people, we're sharing those care journeys with people. Because if we can send someone into hospital for an admission, they're going to be there for a few days, or it's an emergency admission, those hospital passports are essential, because actually they need to know what that person was like before the reason of their being admitted. And we've given them all of that information. If they don't do anything about that, that's for CQC to understand why the hospitals aren't working as part of this quality statement. Single assessment framework. All services regulated by the CQC have to follow these quality statements now. And it actually says we expect providers, commissioners and system leaders to live up to this statement. So as long as we can evidence we've done our bit, so this is this person's usual baseline, this is how they usually mobilize, this is how they usually present themselves, this is how they tell us when they're in pain, this is how they normally eat, this is the diet they normally eat, this is how many hours they normally sleep. All of that information, when they go to hospital or to a different setting, people are aware of what their care journey is. They're aware of what the risks might be overnight. This person usually gets up between 2 and 5 in the morning, high falls risk at that time. So you need to be aware of that. Prevents a future fall potentially in a hospital stay or a respite stay elsewhere. So it's really important that we nail down this care journey stuff and make sure that we're communicating this information to those relevant bodies and those relevant partners. But also that we're inviting the right people in, we're making those correct referrals. We are getting in touch with SALT, we are getting in touch with tissue viability, we are getting in touch with trachea teams or our Abbott nurses, our PEG teams. We're getting in touch with the right people to make sure everyone's involved in what we're doing. Thinking advanced care planning as well. Are we all aware of what this person's wishes are moving forwards? Have we shared that advanced care planning with the surgery, with the nursing teams, our care home teams? Have we shared that information out and kept people up to date of what this person's ceiling of care is? For example, this person does not wish to go to hospital unless it's for X, Y, and Z. Have we got that agreed with GPs? Have we had an MDT about that? Is everyone on that same page? And in those situations, are the family aware as well? Are they aware of what the situation is and what the potential risk of care in certain situations is and why the decision's been made to go in a different direction? Because then everyone is fully informed and fully aware. I mean, the regs for this one, again, it's your Reg 12, it's your Reg 17. But it is really, really important. And again, partnership working, part of their evidence collecting now is all around feedback from our system partners. So working well in these areas is only going to benefit you when the CQC go and ask for feedback around your service. How do you find working with this company? Are they forthcoming? Can you engage with them? Do they answer the phone? Do they contact you when they need to? Are they proactive when they contact you instead of reactive? Oh, we've had this grade 2 for a few weeks and it's turned into a grade 4. What do we do? Why didn't you contact them when it was a grade 1 or a grade 2, depending on what type of service it is? Why haven't you sought that advice earlier? The system partners are there to support us, and actually, it's all important as part of this pathways and this safe systems side of things. Having that openness and that conversation, dialogue with people, and involve them in what we do.
So the only things that I've written down as I was having a look through the quality statements are, obviously, it's around safe systems. Actually, there'll be a number of us out there that during the pandemic quickly put in a digital care system that either doesn't talk to other parts of our organisation, doesn't work for the needs of the business. We're in lengthy contracts. We don't know how to get out of it. There's now not funding for if you want to implement a new system. But actually, if your staff are continuously telling you that the system they use isn't good for productivity, isn't safe, isn't reliable, then actually if they tell the CQC inspector that, it's going to impact your whole rating around safe. So make sure that actually you're reviewing the systems you've got. Are they effective and are they fit for purpose? And do they talk to one another? Because what you want to be able to do is pull the data out of one system that does all of them. There's clear things around handovers in that quality statement. So some of the digital systems do a great job at handovers, others don't. But are they effective? Are they detailed? And are you making sure that there's not missed opportunities for information and cross-sharing between shifts? It talks about continuity. Oh, go on, Adam.
I was going to say, with handovers as well, we always must remember that we can't just have every man and a dog in a handover. Handovers have to be relevant to the people in that handover. So with your care teams, if you're a nursing home, you don't need to give them the full shebang of what the nurses need to know. Your care teams might not need to know absolutely everything the nurses need to know. They just need to know enough to make sure that they can provide that safe care and treatment for that resident on that day. There's a lot of stuff that the nurses might need to know that the carers don't. And actually, we always have to ask ourselves, is it right that we share this information? Do these people need to know this information? Or could this be a detriment to somebody if we share this information? So if you've got your housekeepers, your kitchen team, your receptionists, God knows who else in your handovers, stop that, because they shouldn't know any of this personal information for an individual. They should only know enough information that pertains to their role. And that's really important. So your kitchen team, yeah, they need to know about the nutritional needs, if they're on the Rinse framework or anything like that. But actually, they don't need to know if Joe Bloggs has got a pressure ulcer or all of that ins and outs. They just need to know enough that's relevant to their role as well. So it's around that wise sharing of information.
Yeah, no, that's a really good point. And then it talks around continuity of care. And that isn't just for home care, that's for care homes as well. So again, if you're using a digital system, a rostering system, does it have something like batch allocating, auto allocating? Because actually that's going to look at the geography, it's going to look at the carers, the skill mix, their training, and it will best allocate that staff member to the person that's being supported. And actually what you definitely want if you're supporting somebody who's home care, if it's in shifts, is you want the same person at lunchtime that went in the morning. You want the same person in the evening that went at tea time. Ideally, if somebody's working all day, that person should see that same person all day for continuity. And we know from reablement, actually, that continuity of care, and we all know from home care, domiciliary care that do this well, is actually people identify things really quickly when somebody's not 100%, which means that you can get the medical treatment a lot sooner, you can intervene a lot sooner, avoids hospital discharge. So yeah, definitely have a look at your continuity of care. If you're in a residential home, have a look at what staff are supporting which resident. Just because they're in a care home doesn't mean that that resident should have 5-6 different carers each week with personal care. Actually, can you streamline that in your handover procedure and shift allocation? The only thing I want to draw attention to on the CQC website is some of the quality statements, and this one does have it, is they have subtopics on their website. So the subtopics for this quality statement covers continuity of safe care, safety during transitions, referrals, and also to consider partnership working. So whereas you might have those main what these quality statements mean and the I statement, actually you need to just scroll slightly down and you need to embed those parts, those subtopics into your service as well.
And again, accessible information standards, people with health conditions, people with dementia, people who smoke, people with COPD, people who use oxygen, people who have got all these different conditions. Have we provided them the information? Are they aware around what their health condition means to them and what to look out for if their condition's worsening, so that they are fully informed? I'm going to try and not talk as much now, Mark, I know we've got like another 6 to go through.
I was literally dropping a WhatsApp to my wife being like, I think we might overrun. So let's go to the next one. And a lot of them are kind of intertwined anyway. So the next one is safeguarding. So it is a meaty one. So we work with people to understand what being safe means to them, as well as our partners, on the best way to achieve this. We concentrate on improving people's lives while protecting their right to live in safety, free from bullying, harassment, abuse, discrimination, avoidable harm, and neglect. We make sure we share concerns quickly and appropriately. Any thoughts there, Adam?
I mean, just some real quick fire stuff here. Your safeguarding policy, how is that communicated? How are the team aware of that? Have you got your safeguarding policy up at the entrance so everyone can see it when they come through the building? Roles and responsibilities around safeguarding, are those embedded within your job descriptions? Do you put them in your job adverts? Are you making people aware of their roles and responsibilities around safeguarding? Are people aware of what safeguarding actually means? How are you doing competencies on your safeguarding? How are your team aware of what the competencies around safeguardings are? Do you understand what the safeguarding process is? Do you know what your local threshold is for your safeguarding referrals? So that's a huge one for me when it comes to this. I mean, there's a lot to unpack in safeguarding, and it's one of those areas where we don't want to teach people how to suck eggs, but actually, are we supporting people appropriately? Are we following things through? Are we documenting things correctly? Have we got those systems and processes in place to make sure that people are protected at all times from that? So I'm thinking, have we got no mobile phone usage policies in place so people don't use mobile phones while they're on the floor, while they're supporting people? Risk of abuse, risk of data breaches, simple things like that that are really, really important for us to consider. Are we all working as trained? How are we evidencing that? So a lot of this is just really around making sure that safeguarding is embedded within our team, within our service. People are aware of what it means. I mean, there's a lot of regs to come under with safeguarding. So obviously we've got our Reg 12, we've got Reg 11, which is consent, Reg 10, which is dignity and respect, and Regulation 13, which is safeguarding privileged users from abuse and improper treatment. But then we also need to think around the good governance, the duty of candor, and person-centered care. But for me, with safeguarding, it's something that we should already fully understand and we should fully get. And as part of our daily walk rounds, as part of our service satisfaction questionnaires, our service surveys that we do with people, actually ask the question, do you feel safe? You know, ask them if they feel safe. You know, at any time, if they feel unsafe, you need to know about that so you can remedy it, you can rectify it, you can put things in place. And you're listening to them, you know, you're understanding what they're saying. Dolls is a big one. Have you got a dolls tracker? So it's not good enough just to apply for dolls for people. It's about keeping track of when those dolls are due to expire. Have you got a dolls care plan in place? Are the team aware of what those restrictions are under the dolls? If you're doing stuff that's not as part of your conditions of the dolls, why are you doing it? Does it need a review? Do you know how to go for that review? Do you know how to submit them? Are relatives being informed that a doll's in place? Have they been involved in that mental capacity assessment side of things? Have you had that best interest meeting? So the dolls are a huge thing that you need to focus on, and it is a hot topic. People love looking at your dolls. How are you assured that you're aware that all your dolls are in date? Where's your register? Just make a simple dolls register. Do it on spreadsheet. Do it whatever. Mark and I might put one together. That's a free download. I don't know. We already have done, Mark. There might be one.
Yeah, I was going to say there might possibly be one. If not, we'll get one up.
Yeah, but it's around making sure that you're tracking those effectively and that you're communicating that out to people as well. And then obviously human rights. Part of the PIR is around human rights and how you're evidencing that. So really do some work with your human rights and do that with your team, you know. Do it as a peer supervision, as a group supervision, as a team huddle, gamify it, you know, turn it into a bit of a game. Do you know what the principles of the Human Rights Act are? Do they understand what the principles of the Mental Capacity Act are? So all of that sort of stuff is really great. Nicola Holmes, if you don't know her, go and follow her on LinkedIn. She's absolutely gorgeous and just wonderful and a huge supporter of the Caring View. She has got a document that she's going to send us over, and I'll be sure that we'll get that out to people as well, which is fabulous. So thank you, Nicola.
Nicola's also put, if there's additional restrictions in place, have you updated the dolls team? Very good tip there. The only other bits from me is around training on safeguarding. How often are you doing that training? How are you checking for competency? You spoke around the policy in the entranceway. One thing, LD inspections, always hot, and I don't know if it's the same in elderly services, is around flowcharts for whistleblowing and safeguarding. So the people that use services, relatives, visitors, staff, can see actually once they've raised a concern or a whistleblowing, actually what process should happen afterwards. Obviously, for safeguarding, the CQC want to prevent closed cultures. We obviously have seen Winterbourne View and the other ones, and they want to prevent that. There are a number of subtopics relating to this, so around sexual safety and empowerment, harassment and abuse. The best practice guidance list is absolutely humongous for this one, so do make sure that you set some time aside. The only other thing worth noting is in October of this year, the Equality Act is being amended. So the new Worker Protection Act is coming into place. Employers will now have legal expectations around reasonable steps to prevent sexual harassment in the workplace. So we do have a podcast that we've done with Stephen Scown solicitors. I'll dig out the link. I'll share it. It's an hour long, full of amazing tips and tricks. We've also got a guide that is coming out very soon that we will upload to the website, free to download, covers all the bits that you need and how to evidence it and get you ready. But yeah, do make sure you check that out because that's coming and it won't be long, and we're going to be inspected against that as well, both from a legal point of view, but from a regulatory point of view.
Other things to consider, because I know they're sort of commonplace now in a lot of places, CCTV. Again, that's part of your PIR. They ask you around whether you've had any CCTV or camera surveillance. What's your documentation on that? Have you got the consent for people on that? Are people aware of why you're recording that information? Is it in your privacy policies? But actually, is it in place to support people? Have you got evidence of the impact of how it's benefited your organization? Because if you can say, actually, we installed this and it's prevented X, Y, and Z, mwah, wonderful. They will absolutely love that. And then just another thing to consider is around closed door policy. So have you got risk assessments in place for residents who have their doors closed, who want to have their doors closed, who can't have their doors closed? Have they got the ability to keep that door open if they want to? And I don't mean by using door wedges. Have you got sound activated devices to help keep those doors open? Because if you don't and those doors are always closed, what risk assessment have you got in place to make sure that that person's safe in their bedroom alone with that door closed as well? So it's all of those sort of things that we need to be considering, because if I walk through a nursing home and all the doors are closed and everyone's in those rooms, I'd be going, what risk assessments have been in place for this? Have we care planned that everyone wants their bedroom doors closed at night? I know that I would probably want my door ajar. Is there ability for me to have that? What's the ability for me to be able to open up that bedroom door so that people can non-invasively keep an eye on me as well, as me having that freedom to access the outside? If someone's got advanced dementia, for example, and they can't manage a door handle and we're shutting them into their room and they can't open that door themselves, we might not have locked the door, but what we have done is we've prevented them from leaving that space, and we've prevented them from going elsewhere. It's a restriction, and what risk assessments have we got around that? So it's just something to consider when we think of all those different things.
No, absolutely. For anybody that's in any of the manager groups on Facebook, there was a whole thing around the type of locks, the type of door handles following some CQC inspections. So the outcome was that it was thumb locks that were recommended over anything else. And having a locked door policy and protocols in place if you are locking somebody's front door, and I'm talking about home care there. So yeah, just double check that. I feel like we're on a very whistle-stop tour here. We'll move on to involving people to manage risks is the next one. So we work with people to understand and manage risks by thinking holistically so that care meets their needs in a way that is safe and supportive and enables them to do the things that matter to them. So I think this is kind of what we've spoken about, but kind of builds on that. So around those restrictive practices, how we manage behavior that we feel challenges. Actually, do you have PBS plans in place if you're supporting people with learning disabilities? Do you have mechanisms in place that your staff are trained for breakaway or restraint if needed? How often is that being trained? How often is it being trained and refreshed? Adam, any points to you on this while I read through this guide?
Well, no, I mean, we've spoken about this quite a lot. I mean, there's things that I would be considering here that, again, comes down to that baseline. So do our behavior plans have what triggers are for people? For example, you've mentioned PBS, so I'm thinking, right, well, let's think about triggers. Are we understanding of what these triggers are for people? Pain ad, do we have pain ad scales in place? So have we got ways to manage and monitor people's pain who may be non-verbal, who may not be able to communicate that? How are we communicating other information to them about their risks? So if you've got somebody who is potentially non-verbal but can communicate in other ways, they just can't actually speak, and let's say they smoke, how are we making sure that they understand the risk of smoking? They're living under our services, they're living with our support and our care, they may have multiple conditions, they've got capacity, for example, on this one, but how have we assessed that capacity? Because if CQC come and this person can't talk and they speak and they go, well, how have you done that mental capacity assessment? How have you approached that? What's been your process around that? Have you explained it to them, and then have you given them printed out information and asked them to point to the relevant information that relates to that risk potentially? So they point to cancer, they point to burns, they point to risk of life, they point to COPD or other breathing difficulties. And if they're pointing to the right things, are you satisfied that actually they understand that now and that you've got that capacity assessment in place? So how are we communicating that, and how are we adopting that for their communication needs? Do we need to look at getting interpreters in? So it might be on a day-to-day basis we can meet this person's needs with that limited language barrier, but actually for these big complex decisions that we're having, have we gone to interpreters? Have we gone to people who sign or are experts in Makaton or any other of these other communication aids or tools or language barriers? Have we approached them in really innovative ways to communicate those risks and to understand their feedback back as well? And it is around that balanced approach, isn't it, Mark? It's around positive risk taking. I know during the pandemic, positive risk taking was frowned upon by so many people, which was a shame because we'd made such good headway. But how are we doing that positive risk taking? How are we saying, well, if they don't do this, it's going to affect them in this way, and actually that's more detrimental to the health than actually following through with what they want to do? This person wants to smoke. It's a pastime of theirs. They really, really enjoy it. Not smoking is going to make them depressed. They're not going to be happy. Potential withdrawal issues with them. It could actually produce more challenging behaviors. So it's around weighing up those facts as well and not imparting what we think to be a wise decision on other people. They have to be able to make that decision themselves. We've just got to evidence that we've supported them to do that in the safest way possible.
No, absolutely. Thank you very much. Just had a look through. So it talks around competent people for training. How is this determined? So actually, how have you determined that your manager, your trainer, your senior, whoever's delivering that session, how are they a competent person? What I'd recommend doing is making sure they've done a trainer-trainer course, because obviously then they have to go through a competency part as part of that qualification, and do a trainer-trainer in specific areas, not a generic trainer-trainer. It talks there in the best practice guidance around sepsis, around resuscitation, so embedding them into your training, making sure staff and people you support are aware of the signs to look out for there with sepsis. And then obviously things that we've touched on already, it talks about moving between services, involving people in their risks. A lot of it looks like it's geared towards learning disabilities and or autism services here. So around, involving people to manage risks, around travel training, around supporting people back into education with jobs to take those positive risks on their life. And obviously a reminder that just because somebody might be living in a learning disability care home doesn't mean that they can't go out without staff if they've got capacity and you've supported them to take those risks and they know kind of into the local area. One thing when I got outstanding in my last LD service was around that positive risk taking, that actually people are able to go out, came back at the time that was kind of set, and you need to have boundaries. Make sure that you're involving other professionals in that. Make sure you're involving relatives, especially if you've got relatives that might not feel that their child is an adult because they've crossed that threshold of age, but just to make sure that you reduce those chances of complaints. And you might have to push boundaries. It's a very kind of, for some social workers, a big thing for them to get their head around that actually somebody's in a residential home but might be going to work on their own or something. So yeah, more than happy to speak to anybody around that point.
No, totally. Just a couple of other things just to consider quickly. Are you members or are you part of the, or do you even know about the restraint reduction network? If not, go and check it out. It's all around reducing the use of restrictive practices in health and social care. We always want to do things in the least restrictive way possible. Millions of, well, I say millions, loads of support and resources through the reduction network. And then also just around risks. So we've done our risks, we understand what the risks are, and we're managing that, we're involving people, but actually this person is still going to be at risk if they leave this building alone and unaccompanied, for example, let's say in this situation. Have we got a Herbert protocol signed up and ready to go and give out to people, which details everything about this individual that we know, what potential places where they might go? that allows us to get insight into this person. Where did they live originally? Where did they used to spend their time? Where is it that they called a safe place? Because actually, if they get out of the building, chances are they're going to try and head back to that place as well. So have we got all that information to hand so that actually if someone does leave our service unaccompanied and becomes a risk to themselves outside, we've got enough information then to give to the authorities to go, look, this is everything we know about this person. This will really help you when you're searching for them, because we've done what we can then to manage that risk even further. And it hopefully will give us a really nice outcome rather than a concerning outcome.
Absolutely. So before I move on to the next one, just want to go on. Sorry, Adam.
I was just going to say, so it was Herbert protocol, so HERBERT, I think it is protocol. And for those who don't have him, I will find a link and I will send that out as well.
Perfect, and that is backed by the police as well, so it's definitely a good one to have. I was just going to say, I know, conscious of time, we are running over. You can catch up on the event. I'll just popped it into the comments, so it will be on YouTube. So the next one is safe environments. So we detect and control potential risks in the care environment. We make sure that equipment, facilities, and technology support the delivery of safe care. So obviously what we were saying earlier around actually, if you've got technology in your service that isn't fit for purpose, actually under safe environments, the CQC are going to want to know from your staff actually whether or not it supports them to do the job and to deliver safe and effective care. Obviously, equipment, you need to be making sure that equipment is regularly audited, that it's been inspected, that if you're using hoists and electrical, that it's got the stickers on it, making sure that staff know not to use it, what to do, the protocols to take, obviously, if there are concerns around any equipment. There's a big emphasis on leaders and environments in this quality statement, and around keeping people safe from harm, both physical and psychological. So if you're a leader within the service that you're watching tonight, whether you're a registered manager, a director, CEO, owner, you need to make sure that obviously you have a look at this quality statement. It links back to people managing their own risks, so involving people in that. Talks around premises, so your gas, your electrical, your fire safety. So make sure that you're having people come in on a periodic basis to check the gas, check the electric, fire safety checks. Obviously in fire safety, it's a whole thing in itself around making sure that you've got floor plans, you've got grab bags, that you've got PEEPs, so personal evacuation plans. Ask the fire service to come in and do an audit on your service. They might tell you something different than maybe the local authority or CQC, but what they say is that you should always be following the advice of the fire service. Have you had your smoke detectors checked recently? Obviously, it talks around environmental risks, so your weather, so heat waves, flooding. If you're in the UK right now, in England, 1 minute it is very hot, the next minute it is pouring down with rain, very likely. Make sure your contingency plans are up to date. So we do have a contingency plan template on our website that you can download for free. So make sure that that covers everything. It will give you the bones, you just need to add the meat. Also, if you have got a digital system that is blacking out or technology that isn't providing reassurance to your team or to yourself, make sure you've got something in place that covers that. So actually, if there is a blackout, and we should all have this in our contingency plan, if our systems go down, how do our staff manage? So home care, how are they going to access their rotas? How are they going to access care plans, the medication people need? How are they going to evidence what they did in those visits? So make sure you think about all of that, especially around digital. Adam, over to you.
Yeah, no, just going to echo everything that you said. Make sure your BCPs, your business continuity plans, are literally watertight. If you're going to be without heating, how many heaters do you need? Have you already got those? Are they in storage? If you're out of water and the water goes off, have you got enough bottled water to see you through? And I don't just mean enough for people to drink. Have you got medical procedures that require the use of water as well? And how much do you want to keep in stock? Have a look at things like generators, making sure you're on the correct registers for priority services. I would say... Chris has just come up into the comments.
I was just reading that.
So we were recently told by an inspector that if we don't provide the equipment, e.g. provided by a local authority, we can't audit it as we can't tell if it's faulty. You would only check it's in date. Well, we need to make sure that we're getting the documentation from the local authority that they've done the assessment on that equipment themselves and that we're assured that that equipment's fit and safe to use. So we need to get that from those people if that's what you're being told. I would take concern with the latter part of this, with the local authority saying that PIRs and that they are not required. I have never met a commissioner, a fire officer that have said that PIRs are not required. I would go back and challenge that and ask why. And just because the LA is telling you that you don't need to do that, do you feel comfortable not having those in place? PIRs is in for dom care. Fair enough. That is something I don't think you do need. It would be nice to know what those evacuation procedures are for an individual. So I don't think it would harm you understanding how that person would react in one of those scenarios. I do know there are those tubs you can get that you put in the fridge for people and that have all the information in there. I would just say, as a provider, because the local authority says you don't need to do something doesn't mean don't do it. I would do as much as you can to make sure that that person is safe at all times. So if you leave that house and that building comes on fire and someone comes over to go, oh my God, I need to help this person, how are they going to find all that information about that individual? If the fire service come and they don't know that individual, how are they going to find all that information? Have something safe, pop it in the fridge, because fridges are one of the safest places in a fire. Put a note up in the door, in case of emergency, go in the fridge, look for this item, has all my information about me. You've done that as a home care provider. You've got consent to be able to share that information from the individual. That's only going to go in your favor for making sure that we're meeting not only this quality statement around safe environments, but also that safe transitions, the pathways, the systems, all of that is really, really important. So just because an LA says no, I wouldn't listen to them. I would just go ahead and do it anyway. I used to do it when I was home care. When it comes to care homes, you do need your PIRs, but also have an evacuation register as well. Really, really simple tool. You've got a picture, the name, the room, behavioral concerns and conditions, how that person evacuates, and you've got it on a full register then. So it's easy to put faces to a name. So if we are looking for someone, we can go, yep, that's that person. Make sure that that's up to date. You should have a communication folder at the front of your building. PIRs should be reviewed on a weekly basis in there to make sure there's been no changes. Make sure that they're all within a month date. Your register, I would update that every single week anyway to make sure that is correct. And also make sure that if you are putting photos on your system, on your digital systems, you've got an audit in place to make sure that those photos are relevant and new. Because someone moves into a home in 12 months' time, they could look completely different from when they moved in. And they could have been quite frail when they moved in with you, and now they're actually quite jovial and jolly and plump and happy, and they look like two totally different people. So it's around making sure that all that information to hand is up to date and accurate as well. Also, have a service tracker. So have a tracker within your organization where you've got on there, you know what servicing is due every single month, when it is due, your fire extinguishers, your emergency lighting, your fire doors, your lolas, your lifts, all of that sort of stuff. Make sure you've got a tracker for that. So due on this date, review on this date, or review on this date because it's due on this date, and actually give yourself time to make sure you've got that planned and booked in so you're never without that service. Because if you can't use part of your service and those equipment are not accessible for you to use, it is a CQC notification to say that you've had an incident that's preventing the safe delivery of your service, basically. So it's really, really good just to have that tracker to make sure you're up to date on it. If you've got maintenance teams, make sure that they're on top of that, and just make sure you review that on a monthly basis. I ask all my managers on a weekly basis, have you got any service contracts that are due up in the next 3 months? If yes, what are your processes to make sure that those services are going to take place and that we're not going to be without a service? So just really keeping on top of all of that stuff.
Thank you very much. The only thing I would say to Chris there around the equipment is go back to the supplier of the equipment, because it's likely that they'll have some user guides, manual guides, so that you can kind of upskill your staff on if you're only doing visual observations, but also the equipment service that provided you that equipment from the local authority. They should be able to provide you with that information as well. But I would definitely get a second opinion on that. I'd probably check it out with your insurance company because they'll be able to offer you some advice there. I was just looking around and deeper diving into this quality statement quickly. So it also covers falls, so lessons learned from falls, how you're preventing them. COSH, so obviously control of substances, hazardous risk to health, your slip, strips and falls, PAT testing, acoustic monitoring, falls from windows and falls from height, something that's often forgotten. So do you need window restrictors in place for people that are at risk? Adam, anything else before we move on?
I've turned into Casper the Ghost. I do apologise. I also think, well, I mean, you could go on and on and on and on about this. have you got your window restrictors in, Mark? I know you just mentioned then about that falls from house, but actually, are those in place? Your furniture, are you sure, or are you assured that your furniture is fire resistant, fire retardant? Same with your fabrics. Are we sure that they are safe? Have you got things like your cushions, your soft furnishings, your curtains? Are they on schedules? Are your chairs on cleaning schedules? Are your soft toys on cleaning schedules? We love a fiddle mitt. I really have gone completely white, so I do apologize about that. We love fiddle mitts that are all knitted. Are they on cleaning schedules? So it's around making sure that actually we're assured everything we have got. But you've got a library, it's great, anyone can go in and choose those books. How are we making sure that those books are clean? How are we making sure that we're not giving further risk around those? So it is just around making sure you've got everything included. And I would say around your cleaning procedures, your cleaning schedules, I love a mop and sop. Make sure that the team have got the correct information and the correct products to use. They understand how to use the products and how to clean something effectively as well. It's all super important, because they will say to someone, they'll come and see your domestic team and go, so do you know how to clean this and what you would do in this incident? And they'll go, because it'll slip their mind. But if you make sure that it's on that cleaning schedule at all times, when they're going to sign that cleaning schedule off, they've got that there. Record keeping, monitoring your clinical rooms, make sure that you've got fridges or thermometers in them that you can actually reset, that your team are recording them on a daily basis. Your temperatures to your clinical rooms, make sure they're recording them. Make sure though that if you are recording them and they're recording them out of range, you've got a section on that to say this has been raised to the manager, actions taken. Because if you're identifying concerns in temperature zones, you need to be able to evidence that you've done something about it as well. So it's all around acting on that information you've got, not just recording it, but acting on it as well. So making sure we've got all of those records and that we can evidence that we've done something about it. Otherwise, you're collecting all this information, doing nothing about it. You're never going to satisfy Regulation 17. You'll probably end up with an inadequate or requires improvement for well-led as well as safe.
Just coming back to Chris again, all great stuff there, Adam. I was on the HSE website because it just didn't sit right with me. So provision of a community equipment. So where equipment has been loaned by an employer or community equipment provider or service for private use, i.e. solely to be used by an individual's family or unpaid carers, LOLA does not apply, as it's not defined as work equipment during that loan period. However, in practice, LOLA will apply to the majority of loan equipment provision, as you will not be able to determine whether it's being used solely for private use. Also, the loan period for private use may only be for a few weeks before the equipment is loaned to another individual who has paid carers. If you decide it's not defined as work equipment as the owner and provider of the equipment, you will still have a duty under the Health and Safety at Work Act 1974, Section 3, to provide and maintain safe equipment. This can usually be satisfied by following the principles of LOLA and PURE. I'll share this link in the chat so you've got it, Chris. But yeah, I would definitely seek a second opinion on that. So the next quality statement is safe and effective staffing. So we make sure there are enough qualified, skilled and experienced people who receive effective support, supervision and development. They work together effectively to provide safe care that meets people's individual needs. Over to you, Adam.
Well, I mean, really straightforward for me on this. What is your dependency tool? How are you assessing how many team members you need to provide the care for the people you're supporting? I'm sorry, there is not one size fits all model out there. CQC are going to want to see your thought process. So 130 bed home might have 5 team members working, 130 bed home might have 15 team members working, and that might be because everybody there is advanced needs, they're all double care support, they've got one-to-ones in place. So it's all around how you're assessing the needs of the people you've got and how you're assessing how many team members you need for that. Have they got the right skills in place? Who have you got living in your home at the moment? What are the health conditions? Have the team got that correct skill mix? And is that the variety within your rotas when you're doing them? Gender's choice. Have you got the correct number of or the correct ratio of gendered workers working in your home to make sure that people have that choice and that ability to be cared for by the people they want to be cared for? If you're using agency, make sure you've got a reason as to why you're using that agency, what your plans are to reduce that agency cost. And if you are using agency, what's your process to make sure that agency usage is safe? So you get your induction profiles, your agency profiles. We should all be getting agency profiles. If we're booking an agency member, great. What questions are we asking around the training? Are we asking to see evidence of the competencies of that training? Can they send that over for us? When they're coming to our service, are we providing them with an induction? I know it sucks, but book them to come in half an hour before their actual shift starts and do an induction with them around the building. This is our fire procedure. This is what we do in case of an emergency. This is what we do if there's a meds error. This is what we do if there's a safeguarding concern. These are our fire exits. This is our assembly point. This is the nurse call system. This is the fire panel. Making sure that this is where the kitchen is. This is where the toilet is, etc., etc. Because how are we making sure that when they arrive, they know what they're doing? This is our digital social care record system. This is how you log in. This is how you fill it in. It's a lot of work. Get that. So actually, are we making sure that our agency usage is continuous, it's consistent? Are we asking for the same people over and over? And are we doing our own internal competencies as well? If we're using a nurse and we're using that same nurse for a good number of weeks, are we going to do our own internal competency to make sure that we're happy with the way that they're working? How are you monitoring the training? Have you got training matrices in place? How are you monitoring competencies? We can't just do training, we've also got to do competencies. So how are you recording those competencies? How are you catching up with your team to make sure that they're aware that they understand that training? You know, it's not enough just to do that training. They've got to be able to demonstrate they understand that. Do you share what training you do with other people as well? So do you inform relatives and the residents of what training you do? And are they assured by that level of training? Or do they have concerns? Do they have questions? If you've got days where you're short with team members, what's your process? What's your contingency? What's your business continuity plan say around unexpected loss of team members, be that through travel disruption, be that through infectious outbreak or what have you? What's your contingency around that, and how are you going to manage that, and how are you going to meet the needs of the people? Recruitment, safe recruitment, absolutely paramount. One of my top tips around the recruitment is, we only need 2 references, ask for 4. You know, I know, Mark, you have a different view on this. I think once upon a day you used to ask for 10 or something, but ask for more references than you actually need, because then you're going to get those references through a lot quicker than, say, having only just 1 reference come through. And then you're not going to get to that point where you go, should we just start them anyway? You know, should we just get them in? Making sure we're checking for gaps of employment, making sure we're actually auditing our HR files as well to make sure we've done everything we can do, making sure our induction process is in place. We know what that induction process is. We're having those regular supervisions throughout the induction process. Through that process, they're going through our policies. They're doing all of our training. We're having those regular catch-ups. We're bringing up concerns throughout that induction process. If they're not meeting or not satisfying the way they should be working, we're asking them whether they feel confident, whether they know what they're doing. Have we got something to learn from that induction, so that when we get to the end of the induction, we can confidently either sign it off or fail it or extend it if we need to. So there's lots around the staffing side of things that actually are really, really straightforward, really, really simple fixes. Do you have your fire marshals on shift? Do you have your first aiders on shift? Are people aware of who those fire marshals are? Are people aware of who those first aiders are? Add it to your daily walk around audit. All you need to do when you walk around the building is just ask a couple of team members, who's the fire marshal today? Are they aware of that? Do you share it at handover with your team so they're aware? This is who the first aider is today. This is who the fire marshal is today. You know, it's around making sure that that's all communicated effectively and that everyone's taking all of that in.
Thank you very much. So just having a look, some bits from me. Make sure you've got a training matrix that details how often staff are being trained. Are you doing e-learning or are you doing face-to-face training? And what I would say is, if you're doing all e-learning, that you make sure that you've got a plan in place that you can tell your inspector why it's all e-learning, why there's nothing that's face-to-face. Professional development. So are your staff able to do qualifications? They're level 2, 3, 4, 5, 7. Are they able to do something, you know, around personal goals, whether they want to upskill in AI or wound care or something? DBS checks is something I see in the manager groups all the time. Inspectors that either want to see certificates, don't want to see certificates. What the CQC has said is you just need the ID number of the certificate. So have a spreadsheet somewhere, or if the digital system you use allows you to input that, just have their name, the certificate number, and you can give the original certificate back to that staff member, or if it's a copy, you can destroy it. Performance management. So again, it ties into that closed culture. They want to see that you're actually managing poor performance. So make sure you've got a performance management policy in place, that your managers, your leaders are following that. There's a lot of emphasis around, in a number of the quality statements, around volunteers and unpaid carers, how you manage them, how you induct them, how you make sure what their workload is, the recruitment process. And this one also ties into the well-led key question around well-being. So talks around stress risk assessments. I'll share a link in a minute from the health and safety website on that. Workload management. Do people have a good work-life balance? Are rotas put out weeks and weeks in advance so people can plan kind of personal lives? Have you got checks in place for people that work more than one job, or if you're a multi-site service across multiple services, so they're not leaving you and then going to do a night shift and then coming back to you or something, because we all know that happens. But a lot there around well-being and workloads. Next one. Infection prevention and control. We assess and manage the risk of infection. We detect and control the risk of it spreading and share any concerns with appropriate agencies promptly. Adam, over to you.
So, I mean, it goes back to that housekeeping, the safe environments as well, doesn't it, Mark? Making sure we're aware of how we're cleaning things, what products we should be using, we're using the correct sort of stuff. Are we doing the correct types of audits? Are we doing hand hygiene audits? Are we doing environmental audits? Are we doing PPE audits? Are we spot checking the use of PPE? Are we doing competencies around that? So it's not just enough to do those audits, but actually, are we doing competency assessments on people on hand washing? Are we observing them doing that hand washing and asking them questions around effective hand washing, or when they should and shouldn't don and doff PPE? I want to, as part of this as well, think around infections in a bodily side of things as well. So someone's been identified to have a UTI, or they've got an open wound and it's in the sacral area and they're actually at high risk of infections. Do we know how to search or to look for soft signs of sepsis? Are we monitoring those infections as much as we possibly can do as well? One thing that I'm really, really keen to get started in our own organisation, and I know others would want to do the same, is, are we doing infection outbreak drills? So have we got, and flowcharts are your best key, you know, they are your lifesavers, flowcharts. Have we got flowcharts in place to show how we would react to an infectious outbreak? And I'm not just thinking COVID, I'm thinking C. diff, I'm thinking DMV, I'm thinking scabies, I'm thinking flu. We need a flowchart for each of those. So actually, if we've got more than one case that are clinically linked in the home, we're in outbreak, for example, for a certain thing, have we got those procedures in place? Because the last thing you want is on a Saturday for someone to phone you and go, oh my God, 3 people have got DMV and I don't know what to do. What you want is, I've just let you know, we've got DMV, we've put a one-way procedure into the building, we've got isolation for cutlery, for crockery, we're providing them their meals last, we're cleaning their rooms last, or we've got enough housekeepers to actually just provide them one housekeeper for those rooms. We've portioned off the team, so only certain members of the team are going to support these people, so we're not going into other people's bedrooms. We've followed that procedure. Brilliant. What I want to see across health and social care is infectious outbreak drills. So a bit like a fire alarm. Your fire alarm goes off and you see how your team reacts, and it's a practice drill. What about doing it for infectious outbreaks? So just to let you all know, we've got 3 residents with DMV. Go. What are we processes? What do we do? Go and put all of our procedures in place, and then assess how your team have reacted. Assess their understanding and their knowledge and their response. So actually, you're confident that we know how to respond in those situations. We're sharing that information out with people. We're letting relatives know what we would do in those situations. We're making people aware before they even happen and what's going on. We've got them, like Nicola said earlier on, have we got easy read guidance? Have we got it in other accessible formats for people to understand that? It's quite straightforward for me, this, but it is around your auditing, making sure you're acting on the audits, picking up things like torn wallpaper or chipped paint. Are you going to act on that? Have you picked it up? Have you risk assessed it? Are you going to repair that? Harbours for bacteria, harbours for infection, dining rooms, kitchens, living rooms. People aren't sharing seat cushions, for example. Are clothes protectors, are they individualised for people? Slings, are they individualised for people? Are bathrooms getting completely decontaminated before somebody else goes in and uses them? So it's all around just that assurance. And please, please, please make sure your touch points are on your cleaning schedules as well, and that you're checking on those. I do feel like we'll whistle stop touring this now, but for me, there's a lot of self-explained stuff in this. There's a lot of stuff we should already be doing, but try and think about how you elevate that. Try and think how you do more, and make sure that you've got rooms in your building that you know are going to become waste isolation rooms, so that you can isolate them for say 72 hours before they go out for the rest of the waste. How are you going to communicate your outbreaks to your partners, to the CQC, to relatives, making sure you've got all of that within your business continuity plan, and that you know how to react to team members going down in that situation, and how you're going to replace them, and how you're going to support them under that safe staffing, which was a quality statement back. You're on mute, Mark.
Well, I don't know how that happened, but anyway, thank you very much. Pound in the jar. So there's a huge section on food hygiene. So around making sure that you've got good records there around how you're storing food, cooking food, defrosting food, cleaning the kitchen. Aside from working in social care, I also have an ice cream van that's got a 5-star rating for food hygiene. So if anybody needs some tips around food hygiene, please do let me know.
I was just going to say, things about food that people often forget is when you put things in your freezer, your food delivery comes, great, we're going to pop it in the freezer. Make sure you date it, the date it goes in your freezer, so you know the date that it was frozen. So you can say, actually, it's only been in the freezer a month, or, oh my God, this has been in the freezer 6 months. We really need to get rid of this now. We shouldn't really be using this. Date defrosted as well. Don't take something out of the freezer to defrost and then just put it in there and think, oh, well, that's used by date. Date taken out of the freezer ready for it to defrost, so that you know how many days you've got after that as well. Take temperatures of your food when they arrive from your food delivery services, so that you've got records of that. You don't have to do it all, but spot check your high risk stuff and just make sure that the temperatures are correct on them. And when you're serving your food, if you're using hot lockers, if you're using bain maries or anything like that, take the temperature of the first meal you serve and take the temperature of the last meal you serve, so you can see that actually the food hasn't dropped into the danger zone during that period of that food delivery. You've then got that record as well to be able to use to say, this is how we're assured that the food we're providing people is at that safe temperature, and have those records, by God, have those records in place to be able to evidence that.
No, absolutely. And if you are having food delivered from any of the main supermarkets, you can ask the delivery drivers for the freezer temperature or the fridge temperature on the van, and they will give you that. Talks there around nails. So we all know that we've got a large majority workforce. I'm surprised nails haven't been updated, because I think acrylics are a lot better than they used to be. I don't remember the last time one just randomly pinged off, but there is a whole section around nails. So make sure that obviously they're cut short, not polished, not acrylics. Vaccination is still on there. I feel like the CQC cannot let the COVID vaccine disappear and just let it go, but it's still on there along with the flu vaccine. So make sure you check that out and have records of vaccination of your staff. Waste management is on there, so make sure you check out, are you recycling? Obviously, it's going to be a legal obligation for everybody to recycle by the end of the year. So yeah, what are your waste? What are your clinical waste procedures? COSH, again, we've touched on that, is in there. Make sure you've got an inventory on COSH. PPE also is in there, and a lot of guidance around latex. There are a number of care providers that have gone latex free. So there is a guide on there around choosing safe latex, so do check that out as well. We did have one question that came in on LinkedIn that hasn't been pulled through, but it was just asking, can we explain more around informing families of the training we're doing?
So,
oh, go on.
No, I was going to say, so for me, I always like to put myself in the position of someone whose loved one is receiving care. And I just love to know, actually, what training do our team receive to make sure that we're doing things correctly, and do it at a relatives meeting. You know, you have your relatives meetings or your relatives and family catch-ups or whatever they are. Maybe they're combined with residents as well. And actually just touch base with them and talk about some of the training that you do. Ask them if they want to see some of that training. You know, if you're doing some of that physical training, so say moving and handling, or it, for me, it dispels that. I'm trying to say, it's easy for a relative to look at something and go, oh, God, I don't think they're doing things right there. I'm going to put a complaint in. And they're right to do so, and they're welcome to do so. But actually, sometimes it might be misinformed because the procedures are correct. It just looks wrong to an outsider's point of view as well. So it's around keeping them informed about all of our practices, telling them about our evacuation procedures and what fire training we've had, just to put their minds at ease. You know, they will be asked whether they feel like their loved ones are safe. And if they don't know what training is going on, chances are they may go, actually, I'm not really sure what training they do, but I'm sure they are safe. Whereas if they can go, actually, yeah, I totally think they're safe. They showed us their movement and handling training, and we got to take part in it actually as well. And I could see how they do things, and I'm really reassured because I saw their fire training, and I know what's entailed in their fire training, or their sepsis management, or their pressure prevention management. We're just letting them know everything that we do, and actually that's just going to allow them to feel that bit more safe around the service and be more reassured about the care of their loved one. Plus, when the CQC go and ask them, do you feel like your loved one's safe? Do you feel like the team that's supporting them are trained effectively? They'll go, yeah, totally, because I know what training they do, I know what training levels they're at, and I know what percentage compliancy they're at. I know how they assess their competencies, and I've really got to see that from a first person's point of view as well. So it's just around that open, honesty, transparency side of things, but also making sure that they feel safe around the care and support they're receiving. I hope that answers that question.
Thank you very much. Last quality statement. So medications optimization. So we make sure that medicines and treatments are safe and meet people's needs, capacities, and preferences by enabling them to be involved in planning, including when changes happen. Adam, back to you.
Oh, medications. Where do you want to start with medications? Medicines and treatments are safe, meet people's needs, capacities, preferences by enabling them to be involved in planning, including when changes happen. Medication reviews need to be regular. We need to be documenting this. We need to be involving people at all times. We need to know within the care plans when their last sort of reviews were happening and when the next reviews are due. PRNs, we need to be ensuring that our PRNs are managed safely. So by that, I mean we've got PRN protocols for every individual PRN medication an individual has. On that PRN protocol, it details what the PRN medication is, variable doses, variable times, minimum and maximum doses they can have, minimum intervals they can have. Why is that PRN in place? Because if we've been given paracetamol PRN for post-operation, for example, for, I don't know, say pain to necrophyma, and actually they're given that paracetamol every day, but it's for headaches and stomach pain, we need to be able to review that medication against why that medication's been prescribed, if that makes sense. So reasons for how are we identifying when that PRN medication is due? Can that person tell us when that PRN medication is required? Have we had that conversation with them? Do they understand what that PRN medication is for? Are PRNs being reviewed monthly? They should be reviewed monthly, no longer than monthly. If the PRN medications are being had regularly over that month period, have we had conversations around turning it into a regular medication rather than a PRN medication? PRN records, they tell us when the medication was given, what dose was given, what time it was given. They are PRN, so you can't just have 7, 12, 4, and 9 or whatever it is on your mark sheets and put your PRNs in that. They're going to be at all different times. We do not want to institutionalize that. They do not want to see us offering 7, 12, 4, and 9, or whatever time your medication rounds are for their PRNs, and a big queue in there because they've not needed it. Because actually, what about the other times during the day? Have we got the right amount of team members on during the day so that actually at any point during that day, PRN medications can be prescribed? So documenting those times we're giving them, and documenting times where we've gone and offered and asked if that person needs them, so that actually we're regularly reviewing if that person needs the PRN. If it's around lactulose or say for bowel movements, have we documented within the records that actually they've had normal movements for the last 28 days, that PRN has not been required, it's not been considered for X, Y, and Z. We're backing that up. So reason why we've given that PRN, but then are we going back after a period of time and monitoring the impact of that PRN medication as well? So they've had PRN paracetamol for hip pain, absolutely fine. I've gone back 2 hours later. How are you now? Has that pain subsided? Has it worked for you? Are we documenting that impact? We need to know what the impact of those PRN medications are. We're doing stock checks. We're making sure that we've got the correct amount of stock in place. We're checking the mark sheets alongside prescriptions. We're not just using medications to control behaviors. We're not using that sort of cost restraint on people. Covert medications, we're making sure that if we are having to provide medications in a covert manner, we've got the protocols in place. It's on the deprivation of liberties. We've had the GP involved. We've notified safeguarding. We've notified the CQC. We've had a best interest meeting. The family are aware of this. We've got a mental capacity assessment. We're involving them at all angles. Have we done risk assessments? Have we actually assessed whether this person can self-administer? We can't just bring people into the service and go, we're going to do your meds for you. Have we explored least restrictive options? Have we explored ways in which this person might be able to manage the meds themselves? I've seen a number of occasions in my years in social care where people manage some meds but not other meds. And what's the reason behind that? If they're able to manage some of the meds, why can't they manage the rest of the meds? There might be a perfectly logical explanation about that, but we need to document that. We need to care plan that. It might be that this person knows full well how to manage their paracetamol and can manage that safely. There are no risks of overdose and there are no risks of improper use, but actually they would just feel more comfortable having that paracetamol in their bedrooms for their use. So that they can use it when they want to. If they are self-administering their medicines, how are we making sure that they're storing them safely and correctly? They're not leaving them in their handbag while they nip to the toilet and they've got a bag full of meds in the living room. All around that sort of stuff we need to consider. Self-administration is quite rare within nursing homes or care homes, but it is definitely something you need to consider if you do it. Making sure that your medicines are the correct medicines and are reflective of the best practice and professional guidance. I'm thinking your thickeners here. So things like thickeners, are they stored, locked away? Are they not accessible to everybody else? Emollients, if you're using flammable emollients, have you got risk assessments in place for that? Have you sourced non-flammable alternatives? Have you gone through the mental capacity assessments and the BIs and the risks for the individuals around using emollients? Have you got people who use oxygen in your home? If you do, have you got oxygen saturation risk assessments for your team and for other residents? If it's in use in a communal area, is everyone aware of the risk of the oxygen? Have you got the signs up in the building to say oxygen's in use? This is a risk. Are we aware of all those concerns? So there's quite a bit when it comes to medicine management that we need to take into account. Your CDs, are we booking them in correctly? Are we checking them correctly? Have we got the right amount of signatures for it? If we've only got one nurse working and that one nurse does all of our medicines administrations during the building, who's countersigning those CDs? Because if someone's countersigning those CDs for that nurse, they need to be appropriately trained. We can't just have someone off the floor going, oh, can you just sign this for me because I'm going to give this person the lorazepam. We need to make sure that there's those correct skilled individuals working on each shift so that when the nurse goes to do a controlled drug, there is someone there that can go and countersign it and understands what they're looking for and understands what they're checking for as well. We're making sure that administration's happening in a safe manner. So we're not potting loads of medicines up and then walking around the building with them. You know, we're taking the trolley with us. We're being able to do that administration with that individual on that one-to-one basis. We can check the mark sheets. We can check the pictures. The nurses aren't popping up those medications and then sending them out with other people to go and administer. I would also check on your pharmacies here as well. So if you use MDS systems, if you use pod systems and they're sending you the medications, request from the pharmacies for descriptions of those medicines as well, because you may need to remove medicines from time to time from a pre-made system. And actually, you need to think to yourself, what is that medicine? I can't tell which tablet it is. And if your pharmacy haven't provided you with that information, how can you safely know that those medicines are correct? So really check up on the pharmacies and make sure that you've got all that information to hand. And if that's not working, Christ, go to a rack system, go to original pack dispensing. I'm a huge advocate for original pack dispensing. I believe it keeps us skilled. I know it takes up more time. I know it takes up more space, but actually there's less risk of going wrong because we can count those meds and we are monitoring those meds. Are we doing audits on our mark sheets? How regularly are we doing those? How are we checking for missed signatures? Are we checking medication counts? Are we checking all of those different elements? Are we checking to make sure that on our PRNs, so this is another big one that people seem to miss. So I've already spoken around PRNs having that variable time. So it could be at any time during the day. But actually, what are we doing to check to make sure that when that next PRN's given, it's not within that minimum interval? So for paracetamol, for example, we've given it at 12 and someone's gone, oh God, I'm in pain, I need some medicine. And another person's gone and given it at 2 o'clock. Actually, that's within a 2-hour period of their last dose. Huge safety risk. So actually, how are we managing that? How are we monitoring that? How are our team checked for competencies around ensuring that they're given medicines in line with that protocol as well? There is so much to do here with medicine management. I'm an advocate for making sure that medicines are in their care plans. And so we know what their list of meds are and we can see in their care plans what their medications are. However, that means you need to keep that updated, because if you do not update that when there's a medicine change, that care plan is no longer fit for purpose and does not triangulate with the rest of the information. So you need to weigh up to yourselves, can our team keep this up to date accurately? And if not, let's not put it in there for now until we can get them to that point where they do that. Because if the medicines change and you don't do anything about it, you've opened yourself up to risks, because you could print that care plan off and send it off to someone, and actually those medicines are no longer accurate. But actually, have you got a list of medicines for that individual on their MAR sheet at least, that tells you what their current meds are, when that was last reviewed, when it is next reviewed, any changes that have been followed over. Allergies, make sure your allergies are on absolutely everything. So make sure, even if it's no known allergies, make sure that's on your MAR sheets, make sure it's on your protocols, make sure it's on your medication lists, make sure it's in the care plans, and make sure it's in their care profiles that, they need to be aware of those risks. There's so much more about meds that we could talk. Patch rotation charts. So have you got transdermal patches in place? If so, have you got your patch rotation charts in place? And if you've got your patch rotation charts in place, does your patch rotation chart allow for date administered, date removed, and is there a check for each day? So it could be that this patch only goes on every 7 days. I don't know what that is in hours. So let's say it goes on every 7 days. You put it on a Monday. How are you assured throughout that week that that patch is still in place? So it's best practice to actually check every single day on that medication around to actually make sure that that patch is still in place. So that person is getting that full dose of the medicine. And also for other safety risks, it's not falling off somewhere else and someone else has picked it up or someone else has taken it off. So it's just that added security that patch is still there and it is effective, but that you're auditing your transdermal patches as well. So you're looking for that. Do you know how to dispose of them effectively? Have you got a policy and procedure in place for if that patch falls off, what's your next plan? Do you know who to consult? Is your BNF booking within a year's date? It's all of that information that you need. I've already spoken about fridge temperatures. I've already spoken about clinical room temperatures, PPE usage, hygiene procedures, auditing the cleanliness of your clinical rooms. There's so much to take into account with medicines that it is an absolute minefield, but it's so important that we get that right.
A good deep dive there, Adam. Amazing. No, you're more than welcome. You can carry on. I've got some. So there's a big section around independence. So we need to be thinking around telecare, how we're supporting people to manage their own medication. You touched on it, Adam, around prompting and administering. Actually, do we have clear definitions in place in our policies of what that is for our service? Do our staff understand what that is? A clear sign in your medication room can help just remind people, especially if they're new to delivering and administering medication. Do you have a missed medication protocol in place? What do? You need to be making sure that you've got clear steps to evidence that with your inspector, internal quality teams, directors.
And just Mark, really good top tip for people, especially if you're using agency nurses. Make sure your missed medicines policy or flow chart or whatever it is in your MAR book. So if you've got people who are administering meds in your service that aren't part of your service, they have got that in the book of this is what to do if you've noticed a missed medication. I know a lot of people will go, but we only audit our MAR sheets once a month. It doesn't matter. It's fine. You're auditing them. That's great. But actually, as people who administer medicines, we know full well that best practice is, first thing I do before I administer this medicine is, have they had the previous dose? Is there anything I need to be aware of since their last medication before I administer this one? So we should be picking up on those missed signatures, those missed administrations as soon as we're administering the next dose. But we need to know how to act on that. So as Mark says, make sure you've got that procedure in place, but have it in your MAR book, because then you can follow that process through. And if someone doesn't do that, you've got that accountability angle then as why didn't you follow the procedure that's in the MAR book? Put it in front of everybody's profile if you want to. Have it 17 times, 20 times, however big your home is, how many residents you've got. So actually there's no escaping of what that process is should they notice a medication error or anything along those lines. It just covers you completely.
No, absolutely. Education. So you touched there, Adam, about having the list of medications in the care plan. Actually, a number of times during LD inspections, I had inspectors saying that actually there should be a list of what each medication is for, both for the person that you're supporting to upskill them, but also for your staff so that they know actually what they're delivering, especially if it's coming in a Dosset box or something and you don't actually know which one is what and what they're doing. You need to make sure you've got storage, safe storage. There will be discrepancies, and I've had this myself, and I see it on the groups around PAMS inspections, around what they recommend if you've got medication that needs to be returned versus what CQC recommend. So do make sure that whatever you're following is what your policy says, and you then need to just work out which one, either PAMS or CQC, because there will be conflicting information there. You spoke there, Adam, around oxygen and emollients. You need to make sure around smoking. Have you got risk assessments in place for people that smoke for them? Clear audit trails of action taken if you're doing audits, actually, so you can really evidence what you've done to address lessons learned, what action you've taken if you've noticed somebody's missed medication. Roles and responsibilities of your staff. Actually, do you just have one e-learning course that all your staff do? Do you have face-to-face? Are they transcribing, prescription labels into a paper-based MAR chart onto an electronic MAR chart? Actually, look at that training that your staff have got. You might want to introduce a medication lead so they can upskill staff, so you can put them through some more in-depth training. Practical training. So the CQC website does talk about this, and it links you into the CQC. So it talks about inhalers, eye drops, ear drops, buccal administration, oral syringes. So make sure actually if you're doing e-learning that you're complementing that with something that is replicating those kind of practical elements. Pharmacies. If you're a care home provider, I would ask your pharmacy to come and do an audit of your care home. They're free of charge. They should be doing them anyway. Get them to come in and check your medication records, your policy, your storage, what's going on. They'll give you a report. Again, you can use it as part of your CQC inspection. Make sure if you're doing covert medication, you've got policies and procedures around that. Your staff understand what that means. Learning disabilities, but also now non-learning disability providers around stamp and stomp medication. So stopping the over-medication of people with a learning disability, autism or both, and also now they're supporting treatment appropriate medication in pediatrics. So make sure you check out that. I'll put the link in there, but make sure, because that's now across all services. You need to touch base with what your safeguarding at your local authority says about whether you need to raise safeguarding alerts or not, because there are some local authorities that still expect you to raise a safeguarding for each medication that's missed or if there's an error. And then just preferences. Make sure your care plans detail how people like to take their medications. So do they like to take it with water? Do they like to take it with biscuit? Do they like to take it, with breakfast, just after breakfast? Those intimate things that, make all the difference and will really sell your service for really knowing the people that you're looking after and their preferences.
Yeah, now echo all of that, Mark. I mean, you were saying then something that's completely gone out of my mind, so I'll forget that. But the other thing just to remember is if medicines are changing, we're communicating that with individuals as well, and we're letting them know why those medicines have changed, and we're keeping them up to date, and we've documented that we've had those conversations. If we don't document it, it did not happen. Absolutely.
And I think medication reviews, they seem to get missed off for people that use care services, but actually contact the GP. If you're supporting somebody that's got consultants, make sure you chase those consultant appointments. Being somebody that's under a consultant, I've been chasing for a year. It's a nightmare. I get it. The NHS is in some kind of wacky crisis at the moment. But if you're chasing it for somebody, make sure you document when you've chased it, the time you've chased it, who you spoke to. If you're sending an email, make sure you've got that either on the customer file or you're printing it, however you're documenting that, so that actually you can evidence that to the inspector. So if they actually say that somebody's been on medication for too long or they haven't had a review, you can evidence actually what you've done about it, that you've been proactive. That brings us to the end, Adam, of the first one, safe. I feel like we flew through it, but there was so much there, so hopefully people have found it beneficial.
I feel like we flew through it, but we were at it about 2 hours.
In
all honesty, I do hope people have found it beneficial. I mean, for us, we always use these as learning events for ourselves. Even Mark and I learn from these events when we have our guests on. So we know the Caring View is seen as this podcast. It's a chat show. It's a free resource. But actually start putting it down as stuff that you've learned. So do your self-reflective. Actually, I learned this from this. We're here to help and to increase your offering as individuals, to your services, to your careers, and to the people that you support. And all of this is really just around airing out these ideas around the framework and what we should be doing and what we could be doing. There's so much more when it comes down to medicines. There's so much more when it comes down to everything. Are we doing a stock check every Friday to make sure that we're going, or every Thursday, sorry, to make sure that we're going into the Friday weekends with no shortages? Are we doing checks before bank holidays to make sure that because the pharmacies are going to be closed, we don't need to order or ask for anything else? All these different things we need to be considering. And I feel like we could just do meds optimization as a one episode on its own, because there is so much when it comes to it that actually we need to consider There is no one rule around the audits for medicines, but it's just around making sure that you've justified the stuff that you are auditing and how you're acting on it as well. But let's not continue, Mark, because I'm probably going to get an absolute thick ear when I go downstairs, because I think dinner's been ready for the last 40 minutes.
I was going to say, I heard my takeaway arrive earlier, but it'll be very cold. Just quickly before we do go, I just want two things. Anybody that has found this beneficial, we are going to do it again next week, but we're going to be looking at effective. So I've just popped the link in the comments. So you should be able to find that. So if you head over to YouTube, hit subscribe and hit that notify on the bell, you'll be notified when we go live. But that'll be next week at 7:30. And the only other thing I just wanted to remind people of was our single assessment framework on our website. And again, I'll share the link in a second, but there's a whole ton of free resources on there that you can go on, download, edit, put into your own services. Tools around each of the key questions that we've got. There's a facts section. There's a gap analysis tool. There's a inspection methodology guide. There's so much that's there for free. So do head on over and make use of those free resources.
Yeah, definitely. And Anna, I've just seen you come up in the chat. Sorry that you arrived late. Well, don't worry about it, because you will be able to catch up on this on YouTube. It will be there for ever and a day until the internet decides one day it's no longer going to be there. This show will be on there. This episode will be on there. So go follow us on YouTube, find this episode, and then share that out with your teams as well. You know, I will be sharing this with my teams because there's some great learning for everyone in this. It is on YouTube. You can access it directly from YouTube, or even better, go to www.thecaringview.co.uk and all of our information, all of our episodes are on there. Links to everything that we do is on there. Everything is completely free to access. There's no paywall for anything that we do. So we are trying to make that as accessible for everyone. So if you are late, you're only catching up now, don't worry about it. Or you're watching us on a stream, on a platform that's not YouTube, just head over to YouTube or our website, and everything will be on there. Thank you so much, Anna. We do appreciate that. And as we always say, as long as there's a need for the Caring View to exist, we will continue doing what we do. We can only do this through our great sponsors, such as Prosperwell, CBAT, Care Business Associate Training, Attis Care by Attis Insurance. And I do have to say, Nicola Holmes is the sponsor of the Caring View. So Nicola, if you're still watching us, get us all your information over so we can start singing and shouting about your wonderful service that you provide as well. But Nicola Holmes, huge supporter of the Caring View, has helped us with funding our ventures and what we do. So I have to give her a huge shout out. And we will be getting some stuff from Nicola Holmes up on the website. And again, please do go check her out on LinkedIn. Absolutely an expert in what they do. So yes, we will be back next week. We will be looking at effective. But until then, go and follow us, go and subscribe. All of our stuff is completely free. Please go and get some dinner now, because I know I am going to. Mark, lovely to see you again. And we will be live next week, 7:30, where we're discussing the effective domain of the CQC single assessment framework. Take care and good night.
See you later.